thing. And there was a dog actually I had in one of the clinics in Belfast that I work at, where the owners, whenever it was lying watching TV, Cavalier again, and the owners could hear this whoop, whoop, whoop from across the room. They could actually hear this weird heart murmur from, oh, I don't know, 10 feet away. Very, very odd. The murmur usually is related to the degree of severity of the disease. Well, not so much the degree of severity of the disease, but the degree of severity of the actual leakage that you're getting through the valve. So the more leakage you're getting, the louder the murmur will tend to be. And murmurs will tend to be graded, or are graded, between 1 and 6. Again, you probably know this, 6 being the loudest, 1 being the softest. Okay? So again, another very important thing from a clinical exam is to record, to write down, today Bobo had a grade 3 heart murmur. In 6 months' time you find it's grade 4, well then you know that there's a progression there. You know that it's progressing on. So you get a fair idea as to what's going on. Sometimes they have what's called a gallop rhythm. Normal heart rhythm is lubbed up, lubbed up, lubbed up. And sometimes you listen to these dogs and you hear a... And the reason for that is there's an extra heart sound coming in due to problems with vibrations within the heart because of the leakage. So again, a gallop rhythm and variations in that theme are usually an indication that there's something not quite right. So if that's ever mentioned in the clinical exam, then definitely it's worth investigating. What was that? A fast heartbeat, tachycardia. Again, the heart tends to speed up as it gets diseased, in most cases anyway. And oftentimes we get sort of palpitations, what are called ectopic beats, extra beats coming in. And sometimes that could go on to develop into another very nasty rhythm. In the latter stages in Cavaliers, we sometimes see this called atrial fibrillation. Is that a term anybody's come across? Again, very common in people. I suffer from this too, that's why I'm on the digoxin. And a real problem, because whenever you're in AF, it's not a very nice thing to be in, and you can feel fairly miserable on it. But again, you can treat it with medication. At the bottom there, we've talked about ascites, fluid in the belly. That tends to be in more severe cases, whenever you're sort of at the end stage of the disease. And sometimes you've got weight loss again if they're severe, if they're bad. So going back to the actual diagnosis, cough, which tends to be more at night or after exercise. Respiratory signs, if there's fluid in the lung is called pulmonary edema. Other things you might possibly see are syncope, which is a fancy term for fainting. And then we've mentioned weight loss, lethargy, and absence, all these things that may be present, may not be. So I'm going to turn the lights out here just for a second. Just to show you bottom left, this one. Yeah. I'll turn them back on at the end. There's a few movie clips here. So this is a dog that we're scanning with a nice normal mitral valve. Has many people seen scans on TV or had your own heart scan? Well, just to orientate yourselves, this is the left atrium, this chamber here. Blood shows up as black. This is the pumping chamber, the left ventricle. And the heart scan is like a slice through the heart. And this is the beauty with the heart in particular, because it's a dynamic examination. The heart's a dynamic organ, it's moving, and we get to see this lovely movement of the valves. And there's the mitral valve there. Two little trapdoors, that's the way I usually describe it to owners. There's like a trapdoor that's opening and shutting. But unlike a saloon door, say, which would open and swing back the way, this comes back to the horizontal and stays there. It shouldn't fall down that way there. And that's important, as we'll see in a second or two. So this is the left side of the heart over here. You can just about see the right side as well. Anybody know what that valve's called, the corresponding valve on the right side?
It starts with T, doesn't it?
It starts with T. It's the tricuspid valve. So there's the tricuspid and there's the mitral. And those would be very normal valves. You can kind of see a wee shadow whenever it shuts, see wee lines sort of running down this way. And those are the chordae tendineae that Barbara had mentioned. And they're like the sort of the tent wires that hold the valves in position. They attach down onto muscle on the heart called the papillary muscle down here. And whenever we're doing this echocardiogram, we run an ECG as well. You can see the ECG running at the bottom. And that lets us time what's going on and see what we're dealing with. Okay, this is very early mitral valve disease. This is the sort of thing you would see maybe in a 3.5, 4-year-old Cavalier, which you've heard a grade 1, grade 2 murmur in maybe. And what we're really seeing is a subtle change, but if you look at the valves there, the left atrium looks a wee bit bigger than the last picture. And the other thing is, I don't know whether you can see, but there's like a funny wee clubbed end to the valve there. It's like a wee foot, like a wee triangular foot. Just a wee bit of thickening. The valve itself is still nice and thin and moving reasonably well. And then down below, we talked about Doppler earlier on. And this is what's called colour flow Doppler. And this is a very cool technique that lets us actually see what's happening with the valve. If we look here, can you see a wee tiny bit of blue just there appearing?
Yeah.
Really tiny. That is leakage. That's leakage back through that valve. It's very subtle. It only shows up just about no more. A wee bit hard to see because this wee moving clip's a bit jerky. But that's a tiny little bit of leakage. At that level, we wouldn't worry about that. It's what is termed trivial. Trivial leakage through the valve is how we would sort of describe that. But it's present, it's there. And the valve itself is a wee bit clubbed, a wee bit thickened, ever so slightly. But if we saw this in a young middle-aged cavalier, we would be thinking to ourselves, obviously this is the start of the progression.
Usually what age do you see that in a cavalier?
Well, it varies. I mean, that sort of picture would be sort of characteristic, as I said before there, of a dog of about 3 or 4 years of age.
Right, so we had that at a year old, so it's quite young, isn't it?
If you're seeing that at a year of age, that would be young, yeah, it would be. But again, don't forget, you can sometimes have things at that stage which are more to do with like a developmental problem. It's not so much the inbuilt genetic problem of mitral valve disease. It's more that you can actually sometimes be born with inherent weaknesses or slight sort of what's called dysplasia of valves, but they're just not quite formed properly. So you need to be a wee bit careful whenever you're making an early diagnosis of this sort of thing. Is it truly the beginnings of an ongoing problem in the classic sense of mitral valve disease in the breed, or is it just a wee bit of a malformation in the valve? If you were to take, I don't know, take 100 children off the street randomly and do a scan on them, 5 or 6 of those kids would show leakage like that there. You wouldn't worry about it. And chances are they've been born with just a slight, you know the way some people are born with, I don't know, a slightly bent nose or weird earlobes, or I don't know, just you know, we all have our little foibles which we'll not go into. But you know, these are things that just, none of us is perfect, is what I'm saying. And the same thing applies with the heart. Very few hearts are completely perfect, and if you look long enough and hard enough, oftentimes you'll find things that are amiss there. So at this stage here, I wouldn't be too worried about this. If this dog wasn't showing any symptoms, I would not be treating this dog. I wouldn't be putting it on to veterinary. I wouldn't be putting it on to diuretics unless it was coughing, or unless I could see fluid on an X-ray, fluid in the lung on an X-ray. And I wouldn't be putting it on to the other big class of drug that we use, which are called ACE inhibitors. Are those drugs that anybody here has had their dog on? I'm sure, I know some of you have. These are drugs that tend to end in pril, benazepril, or enalapril. And again, drugs that are used a lot in human medicine for heart failure and also for blood pressure issues. Okay? So this dog, if it was showing no symptoms, I would not be treating it. There's no current evidence to suggest that if your dog is asymptomatic, if there's no symptoms there, that any particular heart medication is going to make a jot of difference. So one of the take-home messages tonight is if you do go to your own vet and they diagnose a bit of leakage in a valve, but your dog is not showing symptoms and they want to put it onto lots of medication, there may be a good reason for that, but ask the question. Just say to them, well, I have been told that you know, maybe there's not an awful lot of point in treating dogs without symptoms. Can you tell me what your logic is? And it may well be that there is logic there, but always ask the question, because there's no point, not that we'll necessarily do any harm, but there's no point in you spending money on drugs. I mean, things like Vetmedin and ACE inhibitors, Forticor, whatever it might be, they're expensive drugs, and on a day-to-day basis over a long period of time, you know, you're spending a fair bit of money. So don't be scared to ask the question.
So Alistair, would that be the same as a dog gets like a grade 4, grade 5 heart murmur, but there's still no symptoms?
Well, that could be different, and that's an interesting question. And the reason that could be different is that if it's got a grade 4, grade 5 heart murmur, it's probably going to be a bit like I'm going to be showing you in a second or two in the next clips, where there's a lot more regurgitation. And if there's a lot more regurgitation, it may well be by that stage that the left atrium, which is a very thin-walled chamber, starts to get bigger, it starts to stretch. And if it is stretching, it could be that the only reason you're not seeing symptoms is because the dog's compensating very well for it. But if there's a huge big left atrium and it's on the point of going, then you might think, well, hold on a second, given the balance of things that's going on here, we might well start onto medication. So if there's a louder heart murmur there and you're seeing obvious marked enlargement of the left atrium, that top left chamber of the heart, the one that was big in that x-ray, if you recall, that chamber there, that's kind of like the biggest indicator for how these dogs are doing. So if it's really, really big, for instance, that last dog, that x-ray I showed you where there was a great big bump on it, that dog needs to be on treatment. It just does, because its left atrium is so big. But you'll see in these next pictures maybe. So that'll be very early. Here we've gone on to another dog. This would be maybe the sort of thing you'd see a year later in the same dog. Okay. That valve looks a wee bit floppy, a wee bit as if it's vibrating. This isn't the same dog, so apologies for that, but this valve here to my eye looks as if it's sort of fluttering a wee bit. It doesn't look as if it's quite meeting properly. It looks as if it's kind of overshooting ever so slightly. And again, it just looks a bit thicker. The whole length of it looks a bit thicker. The previous one, just at the tip, it looked as if there was like a wee foot on the end of it. And this one looks a bit thicker. And even over here, if you avoid the colour, ignore the colour, it just looks as if it's sort of just vibrating, you know, just flapping about. If you look here, you see this little greeny blue area? The blue, which is filling about, I don't know if you can see the blue terribly well. The blue's running down here, and there's a yellow portion in the middle. The blue is blood moving down the screen, so that's blood coming back the way through that valve. That's a one-way, non-return valve. It should open to let blood go up the way up into the ventricle, or actually down in the heart. This is orientated differently. Nothing should come back through. The fact I'm seeing blue there is an indication that there's leakage. The green bit in the middle is what's called turbulent flow, or variance, and that's really, really sort of mixed up flow, a bit like whenever you've got a narrows in a river and all of a sudden you can hear the river because of the turbulence in the river. Well, that's what you're seeing there, but that's probably about a third of the left atrium is filled with a blue, maybe a wee bit more, and that would be sort of moderate, hard to say, moderate mitral valve regurg. And again, there's every chance that that dog might be showing symptoms. The other thing I noticed with that is, if I go back one stage, look at the left ventricle. Okay. This is the pumping chamber in the heart. You see the left ventricle there? See how narrow it looks? It's like a V shape almost, like a wedge shape. Now, look at the left ventricle there. It's like a U shape. It's no longer a V shape, it's a U shape. It's stretched away out. So that heart's getting big, okay? And the reason for that is that blood is pulling in the heart. Because of this leakage back the way, the blood is moving back up, sort of through the heart, back towards the lungs. Blood from the lungs is dropping down into the left atrium normally, going through the mitral valve into the left ventricle, and then it's heading out sort of up that direction where the aortic valve is, off to the body, carrying its oxygen. But here, because blood's going back the way, it's almost as if it's pulling backwards and damming back, as it were. And there's an overload of blood in the heart. The blood isn't getting out of the left side of the heart as well as it should, out to the circulation. And that's why this is stretching. This whole left side, the left atrium and the left ventricle, are starting to stretch. Okay?
Is that irregularity in the ECG trace showing you that as well?
Not so much. It's difficult because you're only seeing 2 beats there. So it's actually quite difficult from... The main reason that ECG is there is whenever I'm making measurements, if I freeze any one frame, that's just a wee clip of the thing, that I was to freeze that, stop it. This little red line that you can see there will stop here, stop there, depending on the freeze frame that I use. And that tells me at what point in the heart cycle I'm actually making my measurements. So that ECG is really there for me to make measurements from. So it's too short a clip to really give you too much information. Can do sometimes, but not always. No, this isn't so good. This would be sort of your 8 or 9-year-old dog that's progressed fairly quickly. And can we see the obvious difference in the mitral valve there? Big, thickened, floppy, and in this case, prolapsing valve. And by that I mean that whenever, remember I was saying to you that the valve should open and should come down to the horizontal? This valve is actually falling back the way. The sheer weight of this big thickened valve is making it fall back the way. So the valve is prolapsing back down, sucked back down into the left atrium. And if you look at the colour flow, the Doppler at the bottom, you can see that blue with the turbulence in the middle. There's more turbulence for a start, but that blue is more or less filling the whole of the left atrium. It doesn't look that much bigger in the left atrium, that's just because of the angle that I'm taking that particular picture at. But this is a really thickened prolapsing valve, and that's an indication that you've got major leakage whenever you see that. The valve just can't be functional. The other big problem with that, again, that's going back to what Barbara was saying, is that valve's big, it's thick, it's heavy, it's pulling back down into the left atrium, and it's being held in position. Can you see the wee line running along there? That's this chordae tendoni that we're talking about, this tent wire that's holding it in position. And the pressure that's on that is getting progressively worse. So there is a chance, at some stage or other, that one of these little wires could just break. And if it does, if it hasn't done already, maybe that's the reason why this valve is prolapsing. If it does break, then all of a sudden you get huge regurgitation and the dog can go into a very acute heart failure.
What diagnosis with this dog then at the minute?
Say again, sorry?
What's the diagnosis for this dog at the minute?
This would be a severe endocardiosis, severe mitral valve, myxomatous mitral valve disease. And again, all these pictures that you've seen are all Cavaliers, all three, and they're all different dogs actually. But
See, this dog wouldn't have long necks then, that was sort of that
well, if you were asking me that question 15 years ago, chances are I wouldn't have had.
Yeah.
Although nowadays, with the help of the drugs, we have things like Vetmed and the other medications. Some of these dogs you can get them stabilised again, and okay, it's the old analogy of a boat with a hole in it, you know, and you're bailing out the water that's building up. But we're now able to bail out an awful lot more effectively than we were before. So, you know, these dogs can go on for a considerable time. The bottom line is not if they go on or not, but how well they're going on, what their quality of life is. Are they happy? Are they able to take a wee bit of exercise and do their stuff? But increasingly, with the help of the medications, a lot of them do. And I think there has been a sort of a definite benefit of quality of life with the advent of these new drugs.
So you're talking about a grade 6 there, Alistair?
If you're listening to that dog, almost definitely that dog would have a grade 6 heart murmur. And a grade 6 heart murmur is one that you almost don't need the stethoscope. If you actually put your hand on the dog's chest and you'll feel a vibration there. And if you feel a vibration, if you feel like what they call a thrill, a wee vibration in the chest, it has to be at least a grade 5, probably a grade 6 murmur. Okay? And the stethoscope, if you do use the stethoscope, you can put the stethoscope on the chest and you can slightly lift it off the chest and you will still hear the heart murmur. That's a grade 6 murmur. If you can still hear that murmur, even with the stethoscope slightly off the chest, that's a grade 6 murmur. So yeah, chances are that dog would have a grade 6. So I was going to just chat about Ben. Ben comes from sort of more County Down direction. And Ben was left in for vaccination. I think it was vaccination. Anyway, it was discovered to have a murmur by the vets in one of the veterinary hospitals that I work out of. And it was a very loud murmur. I'm going to actually just finish up here, but I'm going to talk about a couple of things which aren't mitral valve disease. So again, if there's any questions, do feel free to ask. But these are just to show you that it's not only mitral valve disease that Cavaliers get. It's other things as well. And in puppies in particular, a lot of what we see are congenital heart complaints. And the reason I'm sort of showing these is nowadays we can actually do quite a bit about these things, and we'll talk through what we can do. So Ben, lovely wee pup, but a very, very loud heart murmur. And whenever we did an x-ray on it, we saw a funny bump on his x-ray up here. Now, I know you're not used to maybe looking at x-rays, but there's a weird bump at the top of that picture there. And that gave us a fair clue what was going on. The murmur we heard loudest on the left side of the chest, way far forward. Remember the stethoscope was up underneath the left armpit, under his oxter. We can hear this really loud murmur. And whenever we did Doppler, we saw a lot of turbulence, okay? A lot of turbulent flow. And this is a picture that I haven't shown you before. Do you see a black circle there? That's the aortic valve. And the aortic valve is the valve that's the outflow on the left side of the heart. The heart's got a mirror image, there's a left side and a right side. And the corresponding valve on the right side to the aortic valve is called the pulmonic valve. And the pulmonic valve is sort of hidden here underneath this colour. But it's kind of there. So if you look at that really turbulent flow, that horrible sort of yellow and blue and red mosaic that shows really turbulent flow, that is actually coming at the level of the pulmonic valve. So immediately we start to think, could this be a problem with the pulmonic valve? So what we do is we do the speed gun measurement that we talked about. And this is a different type of Doppler. colour that you saw before is called colour flow Doppler. This is called spectral Doppler. And this would be the same as the police radar, police hairdryer. And what we're able to do with this is to measure the speed of the blood flow. Okay? Normal blood flow in the heart runs at about 1 metre per second. And if you look there, we are getting a speed gun measurement through this valve, this pulmonic valve on the right side up here, just about 6 metres per second, slightly more actually. That one there, I measured at 6.5 metres per second. So whenever we did Ben's measurement, whenever you see that, you know that there's something not quite right. And that was indicative of a very, very narrow valve, a valve that was congenitally malformed and fused in and stuck together and just, you know, wasn't going to work properly. And the analogy I would normally use there, it's a bit like having a hose pipe in the garden and you're watering your plants or whatever and the water's dropping at your feet. Stick your thumb over the end of the hose pipe and all of a sudden, whoosh, you get this big fast jet because you're increasing the pressure. And the reason the pressure was increased was because the valve itself was fused. And I've got rid of the colour here. This is the same picture you've seen before, still image. There's the aortic valve there. And you see these two wee lines here? Two wee white lines? That's the pulmonic valve. And these two leaflets, these two cusps, these two cylinders were just stuck together. They were calcified and they were stuck together and they weren't opening properly. So that meant the blood was having to be really forced through that valve. And the heart was having to do, the right side of the heart was having to do an awful lot of work to get the blood through. So what we did was this, okay? So this is actually Ben's picture. And what we've done here is we've put a little wire, a little catheter, down through the jugular vein, down into the heart, and out through, I'll go back again and show you that again, if I can. Down through the narrow valve, and then at the end of the catheter there's a little balloon, and we inflate the balloon, and that stretches open the bit of the valve that's damaged, basically tears it apart, opens it up. I'll do it one more time, and if you just watch out for it, what you'll hopefully see is whenever the balloon is first inflated, you'll see like a wee pinch halfway up it. And then that pinch should just pop, it should just pop open. And that's it sort of opening up. So just takes only a second to show. There's the wee, see the wee nerve bit, and then boom, it's gone. So we do that 2 or 3 times to make sure that it's nicely opened up. Big panic then is, you see the way we're desperately trying to get the fluid out of the balloon, we're sucking it out, trying to get it out as quick as we can, because whenever the balloon's inflated, there's no blood getting out of the heart. That's not the best thing. So you want to get it deflated again fairly quickly. And then this is the same, this is Ben's picture after the operation. We've done another Doppler examination. And if you remember, prior to the operation, remember he was sitting at 6.5 meters per second? So now he's sitting at 3. Now that's not normal, but it's a heck of a lot better than it was. And you won't get them back to normal again. But if you can get them under 4.5, definitely under 4, really they should be okay. The majority of these wee dogs are fine. So he's not normal, but he's now out of the danger zone. No, he's definitely not normal.
I can confirm that.
but at least the problem is that if you leave them in that sort of, anything over 4.5 meters per second is not good. And most of these wee dogs will rarely will they get to see their 2nd or 3rd birthdays. So touch wood. Everybody else says hopefully
He'll be
Ben
in with you
will.
very soon.
How's he doing?
Great.
I hope you don't mind me
No,
discussing
not
these.
at all.
Yeah.
He's doing
Well,
fantastic.
I wasn't sure you were going to be here, but I thought
He's doing fantastic.
Yeah.
He really is.
So that's his post-operative, and it's roughly down to less than half of what it was, roughly half of what it was before. So if you get into there, that's